Well, hello, everyone. Welcome back. And if this is your first time with us, welcome, welcome, welcome. We're very pleased to be getting started with our clinical conversations session for today. And so my name is Barry Servette. I'm the statewide medical director for MCPAP, and it's a pleasure to introduce our session for today. Our program, as you all know, is a series that we have on the fourth Tuesday of every month. Today's topic is eating disorders, weighing the options. I must say puns are very prevalent in the eating disorder space, so you may even hear more of them. But in any case, our speaker is Dr. Esther Deschamps, and I'm going to tell you more about her background in a moment. But I'm going to start with just a few housekeeping things. One of the first thing to say is just that since very recently, we have been able to offer CMEs, particularly for physicians and nurse practitioners, through the generous assistance of Mass General Hospital, as well as our own valiant staff members who have to do all the work to get it done. So we, all you need to do for that is you need to text a code, which is listed on the screen right now at the top, highlighted in yellow. This code only works for today, but you text it to the number above. And if you're listening on the phone, it's 857-215-2277. That's the number you text to. And in the body of the text, you put the code, which is YETWN. I'm sorry, WUN. I'll say it again, YETWUN. And so you'll get a response, and once you complete, click the link and do the evaluation, you'll get your certificate in the email. So as always, we record these sessions. You can share them with your friends and colleagues, and the recordings are available on the MCPAP website, which is www.mcpap.com. We include a copy of the PowerPoint slides under the toolkits and resources page, so you don't have to worry about taking notes. We will take questions throughout the session. So use either the chat or the question box. And if you prefer, just to indicate that you'd like to be able to read your own question, and we can unmute your line and cue you when it's time to do that. We may save some of the questions for the end, depending upon whether or not the question is related to what the speaker is talking about at that time. So just a few words about Dr. Deschamps. She is the medical director for the Klarman Eating Disorder Center, and she is an assistant professor of psychiatry at Harvard Medical School. She also has a private practice specializing in child, adolescent, and adult psychotherapy, as well as child and adolescent medication evaluation and management. She is a child and adolescent psychiatrist. She received her medical degree from Harvard Medical School. She did her residency program at the Harvard affiliated Cambridge Hospital program, and she did her fellowship in child and adolescent psychiatry at Mass General and McLean, their combined program. She's board certified in child and adolescent psychiatry by the American Board of Psychiatry and Neurology. And she is a very seasoned and deeply experienced clinician in child psychiatry. So thank you again, Dr. Deschamps, and we look forward to hearing your talk.
Thanks, Barry. I will jump into share screen now. And There we go. I think, Barry, you mentioned that I had a lot of slides. So I just want to say that I do have a lot of slides. I'm not going to speak about them each in detail, but I wanted to include them for completeness. So don't get overwhelmed by the number of slides in the talk. I will just kind of hit the highlights as a narrative, with the hope that by the time you're done, you'll be able to understand how to assess, treat the illnesses of anorexia nervosa and bulimia nervosa. I'm going to mention ARFID as a differential for anorexia, and I'm going to mention bulimia as a binge eating disorder as a differential for bulimia, but I won't speak about other eating disorders other than anorexia and bulimia nervosa. This is the illness of anorexia nervosa has been described in the medieval literature. The term was coined in the late 1900s by Sir Gall, and this is a picture from the Lancet from 1936 of a prepubescent teen before and after refeeding from anorexia nervosa. So this is an illness that has been present a long time. This is the DSM-4 definition of anorexia nervosa. And the DSM-4 basically states it's an illness where you restrict energy intake, leading to a markedly low body weight. And what restricting is actually quite variable. It very much depends. Restriction basically means you're not eating enough food. For some patients, that can be cutting down 250, 500 calories a day and slowly losing weight over a long period of time. Some patients progressively cut down on restricting. So you might start out with a patient that should be eating around 2,000 calories. That's down to 1,800, 1,500. Routinely, we have patients admitted to our unit that are eating 800, 500 calories a day. So it can be really, really very profound, profound restriction. And the body weight, if left unchecked, as you know, as pediatricians, you can have patients, if left unchecked, presenting a very critically low body weight. That's the DSM-4 definition. I'm going to jump into my definition of anorexia nervosa. As Barry says, I'm a specialist. I've been in this for my entire career post-fellowship. I started at the Klarman Center, and I've basically been treating eating disorders ever since. And when I think of anorexia, I think of it as a vicious cycle. These are patients that have terrible psychological symptoms. So psychological symptoms, unless you ask the patient, are something you can't see, but they have terrible psychological symptoms which cause behaviors, which leads to the physical condition of malnutrition, which worsens the psychological symptoms. So let me jump into the psychological symptoms. There's a lot listed here that are documented in the medical literature. I'm actually going to focus on two of them. One is fear and anxiety about the ability of food to cause weight gain, fears of eating, fears of weight gain. I had a patient once who wouldn't eat a omega-3 free fatty acid because they had 34 kilocalories a day, and she wouldn't take them because of that extra kilocalories. So irrational fears of eating and fears of weight gain. And much of it is based on body image concerns. So body image dissatisfaction, meaning I'm not happy with my body, and then body image distortion, as you see in this picture of a statue of an emaciated person who looks into the mirror and sees something quite different. So it's well documented that patients with anorexia nervosa have proprioceptive, visual, tactile distortions. As one of my patients said when she was in the refeeding stage, she says, when I start gaining weight, I get this blubbery feeling under my skin. Or another patient who ate Chinese food and looked down and felt that her thighs looked bigger, which is impossible because the food was still not digested in her stomach. But it's the psychological symptoms that interfere with a body perception and a body experience. Those fears, those body image concerns, there's something the matter with my body and I have to change it. I have to lose weight or change shape, lead to the behaviors. And what are the behaviors? Number one behavior is restricting. Fasting is going for more than 8 hours a day without eating. So some patients will get into that. As a matter of fact, in the teen population, a popular thing to do is to start with, they eat breakfast, but then they skip lunch. So they fast all day and then they only eat dinner. So there's that long period in the middle of the day. Exercising can get compensatory, meaning intended to offset weight, food intake. It can also get compulsive. And when someone gets an exercise addiction, they end up with a really, a very guarded prognosis if you can't break them of their exercise addiction. In addition, many patients with anorexia nervosa binge. A common trajectory for the illness is for patients to start out with restricting and exercising, and the majority of patients will adopt some type of binging and or purging behavior. This does not make them have bulimia nervosa unless their weight goes up and they get out of the low weight range. And this is also clinically very important because purging by vomiting or laxative abuse is very medically dangerous. Any patient who's restricting to a great extent and vomiting will end up with risks of hypokalemia and the sudden cardiac arrest that you can see with hypokalemia. So quite concerning from a medical standpoint. Patients may take diet pills or appetite suppressions. Some patients abuse their ADHD meds, the stimulants, which decrease their appetite. They start avoiding eating risk foods, so they cut out on junk food. Then they stop desserts, and then they stop fats, and then they stop brown carbs, and then they stop white carbs. And I'm sorry, they stop white carbs, and then they stop any kind of processed carbs, and they kind of cut down the amount of food they're eating, and then calorie counting and other behaviors. And all of this leads to the physical condition of malnutrition, which affects every single organ system in the body. I'm going to talk about a few. Obviously, the heart, we're worried about cardiac arrhythmias, especially in patients who have low potassium. Low heart rate, low blood pressure are very common. A lot of syncope, a lot of dizziness, a congestive heart failure, mitral valve prolapse. So there can be pretty serious cardiac consequences. Jumping now into bones. As you all know, as pediatricians, you got one shot at forming that strong skeleton. Peak bone mass deposition in adolescent girls is age 13 to 19. And what happens with malnutrition is the osteoclasts and the osteoblasts go quiescent. So you are neither breaking down bone or causing bone to be deposited. And that means in this period where you're expecting bone deposition, your skeleton is just not forming. And you end up with patients who, especially postmenopausal, are at risk for osteoporosis and osteopenia. This is trabecular bone on the left, and this is the kind of Swiss cheese of osteoporosis. The tricky thing about this in adolescents is that often teenagers don't care because they're like, I'm never going to be 60, so like, who cares postmenopausal? Like, that doesn't count. But the reality is, by the time they hit 21, they start caring. And I've had a patient in my office in tears with her bone scan that showed osteopenia at the age of 21, saying, why didn't someone tell me? And I didn't say this, but I thought they probably did, but maybe couldn't hear it at that time. But this is why we consider it an almost emergency to get an adolescent female out of malnutrition. This is a very busy slide. Again, for completeness, I just want to point out how malnutrition affects other organ systems. So I'm a psychiatrist. The brain is my favorite organ. And what we see is in these patients, insomnia, depression, anxiety, and that's the impact of malnutrition on the brain. It's a low serotonergic state where you end up with a lot of symptoms, and some of them actually get better just with bread and butter refeeding. It also is a high stress hypercortisol, so that's a stress hormone. And then again, you're worried about low potassium and low phosphorus. So a lot of different side effects to malnutrition. So that's the vicious cycle. And again, to emphasize psychological, it starts here. Even though the physical condition is so striking, it starts with the psychology, which causes behaviors, which cause the malnutrition, which then have the endocrine changes and the changes in the brain that worsen the psychology. And patients who are admitted at very low weight often want to lose more. So it's an ongoing. On the differential diagnosis, you want to be concerned about ARFID. So ARFID has no body image concerns. Somebody doesn't eat, either it's a sensory integration piece or a globus hystericus where they've witnessed somebody choking, but there's no body image concerns, but you still do want to restore feeding. Mass General has a good ARFID program for any of your patients. Also, medical illnesses, especially GI illnesses, patients can have be shut down on eating for medical reasons, or sometimes you have a psychotic patient or OCD patient who has a hard time eating. And sometimes we at the Klarman Center admit patients with ARFID or psychosis or OCD or even GI illness where there's also a difficulty with eating, because we still need to get the patient eating again to recover in all respects. Let me switch now to bulimia nervosa. The hallmark symptom of bulimia is binge eating. Binge eating is eating what others would consider a large amount of food in a short amount of time in a way that feels out of control. So this might be going to the day-old goods at Au Bon Pain and getting a couple of bags of pastries, or getting a pint or two of ice cream, or getting one or two pizzas. And in what patients describe is once they start eating, they can't stop. Often there is vomiting to kind of, take care of the binge. However, there are patients with bulimia who do not purge, and those patients have non-purging bulimia, and they often feel that they don't have bulimia because they don't purge. So purging is common in bulimia nervosa, but it is not ubiquitous. I'm going to go over the behaviors in my next slide, which is my definition of bulimia nervosa, which is, again, psychological symptoms which drive behaviors. The physical symptom or the physical condition is normal weight. There are physical symptoms, but the weight is not one of them. And then you end up with worsening psychological symptoms and behavior. So let's jump into the psychology of bulimia nervosa. Once again, you have body image concerns, body distortion, body dissatisfaction. Although I have to say this is less pronounced than with anorexia nervosa. I think there's something about malnutrition that really distorts the brain's perceptual processes and their body experience. But patients with bulimia nervosa are concerned about their bodies, their weight, the number on the scale, the shape, their figure, and they want to change it. And they have fear and anxiety about eating. They think about food, eating, weight, and shape. Stress sometimes induces binging. And clinically, very important, there's more shame, because sometimes patients with bulimia say, well, I failed anorexia. Most cases start out with some version of anorexia, and they feel like, well, I failed anorexia, or they feel embarrassed by binging or purging. But the good news is there's better insight, and often patients want to treat their eating disorder. So I actually find it more hopeful, a condition to treat in some ways. So the behavioral symptoms are binging, restricting and fasting. So patients are trying to lose weight, change their shape, and here's the punchline on bulimia: all of the efforts to lose weight, change the shape, whether it's restricting, exercising, purging, taking diet pills, calorie counting, they don't work, and patients end up binging, which means they have to redouble their efforts to try to lose weight. And that's the vicious cycle for bulimia nervosa. And physically, you don't see weight loss that sustains. You see weight cycles as patients lose a little bit of weight, and then binging takes over, they gain weight, and then they try to lose weight, and it's a weight that kind of goes up and down and up and down. And you end up with complications that are related to binging and purging. Again, here's torsade de pointes, the cardiac arrest that you can see if you have clinically significant purging, low heart rate, Purging by vomiting stimulates the vagus nerve. Right along there, you can end up with low heart rate and low blood pressure, even though medically people are not malnourished. We're very concerned about electrolyte abnormalities. We also see a lot of GI symptoms, Mallory-Weiss tears, lots of gastritis and GERD from purging. And dysmotility can happen if patients abuse laxatives. They can actually harm the myenteric plexus and the bowel wall and end up with kind of an atonic colon that doesn't work very well. Dentists are often the first to diagnose bulimia, purging type, because patients will present with enamel loss on the inside of their mouth, which is when the vomitus kind of leaves the oral cavity. And patients might present with carotid and salivary gland swelling due to the irritation of that. So that's the vicious cycle. I don't like my weight. I want to lose weight. I start restricting. I start exercising really hard. I don't eat these foods. And then that gives way to binging. And then my weight is normal, but my weight's going up. So I have to feel worse about myself. And so I do more behaviors. Binge eating disorder is an adult onset often, which is essentially binging without compensatory behaviors. When patients with BED are not binging, they're not often trying to lose weight. They're usually eating normally and sometimes overeating, and a lot of psychological symptoms. This is a pediatric lecture, so I'm not going to spend a great amount of time on it. What's the epidemiology? This is from Udo and Grillo, reported 2018 on a 2012-2013 national survey of 36,000 individuals across the United States. This is using diagnostic criteria based on the DSM-5, not the DSM-4. And based on this, there was a lifetime prevalence with anorexia of about 1%. Bulimia was 0.28. Now, in the past, estimates of bulimia have usually been 2%, usually double what anorexia is. So it's unclear whether because this was a survey or whether patients didn't want to admit that they had bulimia. I mean, it's hard to tell why that's such a low prevalence rate. What we know is that anorexia is more prevalent in white than non-Hispanic, Black, and Hispanic. That bulimia did not differ by race and ethnicity. Women have much more eating disorders than men. This was very interesting. From another study, a prevalence of ever seeking help for anorexia was 1/3 of patients and 2/3 of patients for bulimia, which means that we're missing treatment for an awful lot of individuals. And then it also is important to mention that there's a high rate of eating disorder in gay and bisexual men more than heterosexual men. So how do we assess it? First, make the diagnosis. It's often don't ask, don't tell, but it's different reasons why it's don't ask, don't tell. For anorexia nervosa, patients are afraid of weight gain. They don't want to come to clinical attention because they don't want to have anybody make them gain weight. For bulimia nervosa, they often don't want to come to clinical attention because they're embarrassed. On the other hand, if you're upfront and say there's treatment and there's help, they're often very willing to accept that help. So we always tell parents to look for clues and ask questions. Here's some clues. As I said, with anorexia, and the natural history is weight loss. So I had a patient who presented once with mononucleosis, and she had lost 4 pounds. Everybody said it was mono, but then she kept losing weight. And by the time she lost 30 pounds, the family realized this is actually anorexia. But it's that downward trend, and it can be very clinically significant weight loss. For bulimia nervosa, again, you're not going to see an underweight patient. You're going to see a patient whose weight might go up and down and up and down. Dieting, but dieting not like usual diets, which cut down 250 to 500 calories a day. This is significant restricting, where the amount that you eat gets less and less, and patients get into the neurological habit. So that's something that you do so much that your brain kicks in and the striatum kind of kicks in, and they get into the habit of not eating, and then it's harder and harder for them to eat. calorie counting, taboo foods, I can't eat this, I can't eat that, excessive exercise. Sometimes patients who purge will go to the bathroom after meals. They might find vomit, laxatives in the bathroom, a focus on body appearance, and then some of the medical signs, Russell signs, knuckle abrasion from self-induced purging. This is a handy tool to kind of screen patients who are at risk for eating disorders. If you get 2 positive on the SCOFF, there's a pretty good chance that there's a clinically significant eating disorder. So what are the questions on the SCOFF? Do you make yourself sick because you feel uncomfortably full? You're actually asking someone if they purge without saying, do you purge? Do you worry that you've lost control over how much you've eaten? So that's a symptom of binging. Have you lost more than 1 stone in a 3-month period? So that's 14 pounds. And this is psychological, do you believe yourself to be fat when others say you're thin? And would you say food dominates your life? So that's a symptom of thinking about food, eating, weight, and shape that patients often talk about, that one of the problems in anorexia or bulimia is that all they can think about is their eating disorder. And it shuts them, kind of takes them away from their schoolwork, it takes them away from their friends, it isolates them for their family, and it starts taking up more and more psychological space. This is a slide that I have included for completeness because it's important to know that it exists. I believe it's available on the internet. Christopher Fairburn is an international expert in eating disorders. He wrote the book, Cognitive Behavioral Therapy for Eating Disorders. I have no conflict of interest, but I do own the book, and I do actually do the cognitive behavioral therapy that Dr. Fairburn teaches. It's a clinician's manual in there. And in both research and in clinical practice, the eating disorder examination questionnaire looks at symptoms in the last 28 days and asks patients a number of questions. And we basically say, over the last 28 days, on how many days have you restricted or fasted or had a desire for an empty stomach? How many days have you feared weight gain? How many days of binging? How concerned are you? So it gets at all the behavioral symptoms, psychological symptoms, binging, purging, weight, body concerns, and there's subscales in it. And it's a very handy tool that you can, if you get trained, administer in about 10 minutes, and it gives you a great snapshot of where the person is with their eating disorder. So I've included it for completeness. So continuing on the assessment, the first thing we want to do is a medical workup. The second thing is take a weight history. And then there's something called the iceberg. I'll keep you in suspense on that one. So what's the medical assessment? I already went over the medical complications of malnutrition and purging. I would include them, in a careful review of symptoms for your patients. We check orthostatic vitals, which are very common. Again, I have patients admitted to my unit who have bradycardia in the 30s. Usually I'm not that concerned as long as their blood pressure is holding, but it is a precarious medical state if they can't resume eating. I think a natural history of eating disorders, particularly anorexia, is that a teenage girl will present to their doctor and they'll be too medically unstable from vitals to go home and end up getting admitted to the pediatrics. In addition to the normal screening labs that we do on our inpatient units, we also add magnesium, phosphorus. So phosphorus is a key electrolyte, so ATP and a number of other. When patients are malnourished and not taking in food, they deplete their body stores of phosphorus and of potassium. When they start eating again, insulin causes potassium and phosphorus to go into the cells, and you can end up with hypophosphatemia, which can lead to a dangerous refeeding syndrome. People historically, Karen Carpenter used to die from refeeding from anorexia nervosa. In our unit, we routinely give Fosnac to patients when they start the refeeding process, and we go up slowly on their meal plan. Urine pH, the pediatricians at Boston Children's told me that rather than using salivary amylase, which can be elevated when people are vomiting, urine pH can often be a more sensitive indicator, such that if it's elevated and alkaline, that's an indicator that patients are vomiting. and an EKG. So I apologize, BMI like this is for adults only. So I should have adapted it for the pediatric world, but I give this talk also to the general population, but this is only valid. As you know, for peds, you have to look at the growth chart or do percentage of BMI, but for adults, calculator.net or weight in kilograms divided by height in meters squared with for adults, a BMI of 20 to 25 is normal. And for adults, again, a BMI of less than 15 is extreme anorexia nervosa, and BMI of 12 and 13, and to some extent 14, can be associated with sudden medical death. I put this in the red zone because I also want to highlight that patients often water load or tape weights to their bodies or eat cucumbers, which don't have a lot of calories, but a lot of weight. So you can never be quite sure when someone's presenting to your office what their weight truly is. And so you have to really kind of, when they're getting down to these low weights, you have to actually be pretty concerned. Because sometimes, even at the Klarman Center, we've had patients whose weight is 10 pounds less than we think it is. So it can get into critical condition. A weight history, I'll ask a patient, here's an example, a 22-year-old woman, 5'6", she's 104, so her BMI is 16.8, moderate to severe anorexia. High weight is 115, BMI of 18.6, so she's never been a normal weight. A low weight of 80, BMI of 12.9, that's death's door, and a desired weight of 99, less than that 100 pounds. She wants a 2-digit weight. So she actually is low weight, but wants to lose more. So that's a common weight history. And patients will often share that with you if you ask in a pretty straightforward way. Whereas bulimia, you might have a 28-year-old woman who's 5'7". A weight varies from 130 to 155, depending on how successful she is in her restricting and weight loss episodes. And she wants to get down to 125. So this is the iceberg. What we know about an iceberg, and this is pretty true of a lot of psychiatric conditions, is what you see on the surface, in our case, eating disorders. There's a whole lot under, and you have to figure that out, because unless you take care of what's under the iceberg, you're not treating the whole patient. So what's under the iceberg? Adverse childhood experiences. In that national survey, I think they estimated like a half to 2/3 of patients reported adverse childhood experiences. That's our trauma, neglect, abuse. And what we know is stress shuts down on feeding, and that's a very common part of the clinical picture. You can also have teasing, often about weight, bullying, exclusion. Teenage drama can count as stuff that bothers teenagers. School failure, school stress for New England students. It's so stressful to be a junior in a New England school. Learning disabilities, family discord, divorce, moves, financial stress, illness, personal family illness, COVID, and a lot of comorbid anxiety, depression, substance abuse as well. So jumping in, how do we treat the vicious cycle? How do we treat these illnesses where psychological symptoms drive behaviors which cause a physical condition? The first thing I do when I'm seeing any new patient is I triage for the danger zone. I just reviewed a book that's being published on medical crises and eating disorder, and the author pointed out that, these are precarious patients, but you never know how close they are to getting into trouble. And so, someone who doesn't have reserves can get into sudden cardiac arrest pretty quickly. Their electrolytes can drop. They can get very suicidal. Anorexia nervosa has a very high suicide rate. So to just make sure that you're prepared if a patient walks into your office, some of these patients should not go home. They should go to the ER and get admitted either to psychiatry or from a medical basis. Switching now to the treatment of both anorexia nervosa and bulimia nervosa. Regular eating is a term coined by Christopher Fairburn. That means you want to get patients back to eating breakfast, lunch, snack, dinner, snack on a regular basis. And for many patients, that's absolutely not what they're doing. But you start slowly and you work on reestablishing meals. At first, we care about them eating regularly, and then we want to get them to eat sometimes more food or more variety, but we want to get them back to regular eating with more food variety, eating in a variety of settings. And we really want to watch for any compensatory behaviors such as, well, I've started eating, but then I go and purge to make up for it, or exercise to kind of burn off what they're eating. For anorexia, you always have to weight restore a patient. So there's no recovery from anorexia nervosa without getting a patient back into a full, healthy, weight restored weight range. What is a healthy weight range? For pediatrics, it's often returning them back to their growth curve. So where their weight would have been, should have been, could have been before the eating disorder. For adult women, sometimes it's getting them back to their premorbid weight, or to usually a minimum of 92 to 95% of average body weight is where most women have normal menstrual and endocrine function. But that can vary greatly depending on how, what their build is. I had a patient who was a lacrosse player who had anorexia. And I think when she recovered, she was, on the higher end of the BMI. And she said to me, Dr. D, no matter how much weight I lose, I'm not going to be skinny, because she was just a solid lacrosse player. And she was accepting to get her body back up to where she wanted to, where it physiologically wanted to be. Outpatient, we go for 0.5 pounds a week to 1 pound a week. So that's an excess of anywhere from 250 to 500 kilocalories a day. On our residential unit, we can get up to 4 pounds a week, which is really helpful, even though it's a lot of food and it's a lot of weight gain in a short amount of time. If someone's down 30 pounds, you don't want to mess around, and you want to get them back to their lives. And so you don't want to have them be in the hospital gaining weight at a pound or 1 or 2 pounds a week. You really want to kind of get them back to where they should be. And I think I mentioned the refeeding syndrome of low phosphorus. So here's another schematic: regular eating of adequate calories, variety of settings, food variety, no purging, normal exercise. So what goes wrong and what contributes, I'm going to just speak for anorexia, with the high relapse rates, is patients will get refed, they will leave, they'll cut down on their calories. They'll struggle to eat different places. They will actually struggle to eat fats in particular. Some will start purging, and then some will exercise excessively, and then they'll end up getting trapped back in that vicious cycle. So it's really getting them into a full recovery space. I think it's worth to spend like 2 minutes on binging, because patients with bulimia will often come in and they'll be like, I really want to give up my eating disorder. And I'll say, you want to give up binging and or purging if they purge? And they say, yes, I want to give that up. And I say, how about giving up the rest of it, which are trying to lose weight and change your shape? And they say, no, I want to keep that part. I just want to give up the binging part. And my job is to say, they're part of the package. So I do something, and this again comes from Christopher Fairbairn's CBT for Eating Disorders, a binge analysis, which is what causes binging. So for many patients, hunger causes binging. So the word bulimia nervosa is Greek for ox hunger. So patients are not eating. They get up, they don't eat breakfast, they don't eat lunch. They might eat a snack after, sports, because they're starting to get dizzy. They come home at night, they eat dinner because they don't want their parents to be kind of clued in about the eating disorder. And then after everybody's gone to bed, they'll go binge because they're driven by, they can't resist the hunger. And in often what people binge on are the foods that they don't allow themselves to eat. So food rules in diets are, I can't eat this, I can't eat that. This diet includes these foods and this diet does not include these foods. In eating disorders, that gets more severe. And so one of the things that will happen in diets is people will eat a chocolate chip cookie, which is not on their diet plan, and then they'll eat more chocolate chip cookies. It's an all or nothing thinking. It's a normal response to denial. In eating disorders, this happens as well. People will say, I'm not going to eat this, I'm not going to eat that. And then they will end up binging on it. And I think it combines with hunger, because often simple carbohydrates, which probably help with hypoglycemia, that is a result of hunger, is often what patients will binge on. So there's both a psychological drive to binge, but there's a physiological drive to binge. Patients will get emotionally upset and find that they binge. Some of the emotional upset is about their body weight and shape. So a lot of what we do is work on body acceptance, like where your body is, you have to accept it and not try to change it. And any efforts to lose weight or change your shape will just give you more emotional upset and really increase your risk of binging. So we work a lot on body acceptance. And then drug or alcohol inhibition. I mean, patients, when they drink, will get disinhibited, they'll eat more. Marijuana patients will end up eating more. So when you treat binging, you want to treat what causes binging, which is to get patients to stabilize their binging, which is the first thing you want to do, is you want to treat hunger with regular eating. So you're taking away that physiological drive, you're taking away the limbic, the insula, which governs foraging in animals, and you're making sure that insula is not lit up saying, give me food, give me food. So you're trying to make sure physiologically they have enough food. You want to get them to eat a variety of different foods so they can actually be comfortable with a variety of different foods, but also physiologically not have their body saying, I need carbohydrate, for example. That's a good example. If patients go on a high protein or high fat diet, their bodies will crave carbohydrates. You also want to treat emotional upset with skills. We do a lot of CBT, a lot of DBT, and then sobriety ensures a clear head. Sometimes it's hard in this age population to say, I think you shouldn't drink, but we often say, can you hit the pause button and take 6 months off of drinking, or drugging, or your marijuana use, just so you can get your eating disorder under control. Because what we know from the literature is if patients leave and continue to drink or drug, they're back in the soup with their eating disorder right away. And the same goes, I think, on the substance abuse units. When people get their substance abuse under control, but their eating disorders untreated, it's often kind of destabilizes them enough that they're back in. What do we know about therapy and medication? Therapies have evidence of efficacy for bulimia nervosa and anorexia nervosa. For example, family-based therapy for anorexia nervosa for children and young teenagers, I think, has about a 50% rate of efficacy and avoids hospitalization. I like cognitive behavioral therapy for bulimia nervosa, but there's other therapies as well that have evidence of efficacy. A study, 16 weeks of fluoxetine, 60 milligrams versus 20 milligrams. There was decreased binge purge frequency, more with the 60 than with the 20 milligrams. However, as was pointed out, these studies are only 16 weeks. And so we don't know what will happen with patients as they go on, whereas CBT probably has a more lasting effect. And so we consider that a frontline treatment. Medications for anorexia have limited efficacy. There's some wish and hope that atypical antipsychotics could be helpful. And of them, olanzapine, I think the study was 6.3 milligrams in a partial hospital patients. Patients had a higher rate of weight gain. However, and Barry, you can tell me if you agree with this, often when you say to a patient who has anorexia nervosa, I'm going to give you a medication that will increase weight gain. And it may increase weight gain by increasing your appetite. It may also change your metabolism to cause weight gain. Most patients with anorexia will be too afraid to take a medication. And if you start a medication without really consenting them to the full side effects, you're not supposed to do that. You're supposed to do a full informed consent for any medication of all their side effects. And so that can be problematic. Also, I've had a couple patients who came in on olanzapine who were not consented, who were binging because olanzapine caused them to binge, and in their restrict binge cycle, it was very upsetting to them. So in general, I don't tend to use olanzapine unless I fully consent the patient and there's a plan to taper it off as they approach weight gain. And we also have to watch out for medication side effects that are problematic. For example, Deseril, also known as trazodone, is a very common sleep medication. I use it all the time, but it can really drop blood pressure. And these patients are way more sensitive to things like dropped blood pressure. Stimulants can be tricky in patients with anorexia because I always say if you're not eating your meal plan and you're losing weight, the hypoglycemia will cause such problems with concentration. I'm not worried about treating your ADD. That's like lower on my problem list. But if you're in a healthy weight range and you're able to eat your meal plan and ensure adequate nutrition, it can be very reasonable to use stimulants. And you always want to treat the comorbid conditions that go along with anorexia nervosa, and especially the iceberg. Unless you treat the iceberg, the patient will leave in a healthy weight range, but in just as bad a condition. At the Klarman Center, we do 3 times a week individual therapy, twice a week family therapy, psychiatry, art therapy, body image work. Because unless you really help patients with all the other stuff, they really, I don't think they can really get out of these eating disorders because they're too complicated. I know we have about 15 minutes. I'm just going to buzz through levels of care and prognosis, and then we can have questions. The usual level of care for anorexia nervosa very reasonably can be outpatient. If the patient is in medical trouble, and if they have a contract and a plan and they're working with their team, which is usually a therapist, a psychiatrist, a dietitian, and a primary care, and you're monitoring their weights and they're increasing their meal plan and you're checking their labs and their weight is gradually increasing by that pound a week. The problem is for many patients, they have a hard time gaining weight outpatient. And as I say, it's no failure. Sometimes they need intensive outpatient, which provides usually like 1 meal in a group and some more support, or partial day hospital so they can sleep at home in their own bed, but get a couple pounds a week on them. For patients who can't make it at lower levels of care, I think residential is an excellent option to be able to both work up everything that's around the patient and to reliably get them weight restored in a pretty time efficient manner. The negative of residential, of course, is that you pull someone out of school, and that can be really, really difficult for these teenagers. Inpatient psychiatry, we don't recommend unless the patient is suicidal. The way we use it at Klarman is if we have a suicidal patient who can't be cleared that they'll be safe on our unit, we send them to an inpatient unit where we try to get them back as quickly as possible, because they often on our inpatient units do not treat the eating disorder. There are other programs that have inpatient eating disorder programs that do treat the eating disorder as well as other comorbidities for patients who might need that higher level of care. And then inpatient medical is often where patients start, because they'll go to the pediatrician and the pediatrician will say, whoa, not only have you lost a lot of weight, but your heart rate is 27. So we're going to unfortunately have to admit you to pediatrics. For bulimia, outpatient level care is the standard of care. Patients might benefit from IOP or partial if they're struggling, especially with a lot of comorbidities. Sometimes, again, residential can be super helpful when a patient can't stabilize their binging. And in a couple weeks of not binging, patients are often incredibly relieved and can get up and started on that regular eating that can make all the difference. And again, inpatient psychiatry is really only mainly for suicidal thoughts. So one word on prognosis. This is an old meta-analysis from 2008 based on lots of different patients. Steinhausen the epidemiologist who did it said that the results were so disparate that these can only be taken as trends to the mean. But in general, we think that anorexia has about a 5% mortality rate. And we think that 20% of patients develop this heartbreaking condition of severe enduring anorexia nervosa, which is chronic anorexia. And it's heartbreaking. I treat severe enduring anorexia nervosa, it's heartbreaking. The best prognosis for a teenager, which is usually when anorexia has an onset, is to come into the hospital, get into full recovery, and really watch relapse prevention. Otherwise, you get these kids that develop their identities and it just kind of becomes part of their life, and they're more likely to become chronic. About half the patients recover. Some patients, a good amount of patients have improvement. Another 24 outcome studies that Steinhausen reported on had bulimia nervosa with a 0.7% mortality rate, a good amount of recovery and improvement, and again, some chronic symptoms. This is Scott Crow, University of Minnesota, comparing patients in an outpatient eating disorder clinic. So this is not population, this is clinic-based sample over 25 years, and looking at the National Death Index and saying, what happened to these patients? What's really interesting about Dr. Crow's analysis is, first of all, we see the mortality rates for anorexia. That's pretty expected, 5%, 4%, that's the same. But a lot more mortality rate for bulimia nervosa and for EDNOS, which used to be in the DSM-4, subsyndromal anorexia, bulimia, and binge eating disorder. Much more mortality for bulimia and EDNOS than we had thought about. So more concerning clinical symptoms. I have 2 adult vignettes. Again, I apologize, I'm using my adult slides here, but I know that we only have about 9 minutes, so I can leave the vignettes for people to read, and I can take questions, or I can go through the vignettes. What does everyone prefer?
Sure. I think why don't we leave that slide up with the vignette so people can read it. But there are a couple questions, and I think we might want to just go into those questions now, since time is running short.
Sure.
So Catherine Ward asked the question. I'm going to read it. She said, the majority of my eating disorder patients do not meet criteria for hospitalization, and ED programs have months-long waiting lists. Knowing that early weight restoration is key, how can we as PCPs support this important time in recovery while awaiting specialty referral? I've read the family-based treatment handbook to familiarize myself with the mainstays of treatment, but I'm not a psychologist and cannot offer that important piece of treatment to my patients, nor can I find many community therapists who are trained in it. So what would you say about that? That's an interesting question.
So quick question, Catherine, are you in Boston Metro or?
She's having some audio problems with the computer.
Got it. Okay. So, all right. So first of all, I want to say, don't worry if a patient, it's tricky, and I should probably talk to my intake coordinator. Depending on the insurance company, the Klarman Center has had good success admitting patients who don't meet weight recovery, which is how the insurance companies think of it, for anorexia nervosa, because in this adolescent population, you can have a 20-pound weight loss, which can be medically significant, even if the patient is not below body weight. Or you can have teenagers that have complex comorbidities or some comorbidities. And we've actually been able to sell to the insurance companies, like Blue Cross is my favorite. I've never had a patient admitted who was kind of iffy on the meeting criteria. They just cover them. And without a lot of back talk either. Some of the other insurance companies you have to kind of go to bat for a little bit. And then sometimes we end up only with partial hospital level of coverage, and the parents can pay an overnight fee. If they can't afford it, they can qualify for a rate reduction. We also have a pediatric scholarship at Klarman where a family has given funds for families who can't afford care that's not covered by insurance companies. So don't be afraid to reach out to, or have the family reach out to the intake at the Klarman Center to say, you know, is this a possibility? I'm worried about this kid. I think in my private practice, when I see someone, if they're underweight, unless it's just a little underweight, I kind of give them like a couple months. And if they can't get on board with gaining weight and getting back on their way to a healthy weight range, I like hospitalize them. And I don't mess around with partial. I just go right to residential just because I run a residential program, so it's easier for me. But you could also reach out to the partial hospital patient programs, and sometimes that extra support can be helpful. So there's a number of local partial programs. So
Esther, I think that there may be, I'm reading between the lines a little bit. Actually, by the way, Catherine's from Western Mass.
Western Mass.
I think that I'm interested in your thoughts, and she may have also kind of been looking for some feedback about how you can sort of use anticipatory guidance, counseling, and primary care setting to begin or to sort of help prepare patients for family-based care. Yeah, or
Okay,
even family-based treatment. Are there elements of family-based treatment that you can sort of start while people are waiting?
Right. So family-based treatment could be, I could spend a lot of time on it, but it's basically the Maudsley approach. It started in England. And in family-based treatment, the parents take control of food and eating. And they basically usually work with a dietitian or a psychologist. And I think a dietitian would be the way to start here. Get a dietitian to say, what should this person, you know, my child be eating? And then you sit down the child and you say, oh, here's your breakfast. And you have to remain neutral. And you have to say, you know, you have to eat it. And younger kids will often do that. The problem is many teens, and especially if there's any discord or disruption in the family system, and if the anorexia is related to any family system upset, often FBT won't work because it doesn't take into account the stress that the child is under. But if it's a fairly non-complicated, you can sometimes get the parents to basically work together, send them to the school to have a bag lunch with the nurse, pick them up after school, stop their sports, which are burning a lot of calories. Make sure everybody sits down as a family. You plate it for the child, you put it in front, you wait for them to finish, you call them for their night snack, you hand them the food, you wait for them to finish, you remain neutral. But you kind of tell them, like, if we can't do it at home, we're going to have to do a higher level of care, and we don't want to do that. And you can't return to sports until you are kind of on the road to recovery, where you're gaining solid amounts of weight. Parents should know that as a child refeeds, they will need increasing amounts of food because they will get hypermetabolic. So as they shut down on eating, their metabolic rate lowers, but then as they start refeeding, they'll have higher metabolic rate. Parents should also know that kids and teenagers might hide food, or they might exercise surreptitiously, and they might do all kinds of stuff, and not to get mad, because it's just their eating disorder. And we're just doing the best we can to try to help them overcome this. And then they should also look for, if there's no eating disorder specialist in your area, look for a non-eating disorder therapist to try to talk to the kid about what else is going on. Because sometimes there's lots of stuff under the surface that is stressing a child, and that's shutting down on feeding. And if you can help them with that, often, kind of that can loosen things up. I don't know, Barry, if that was.
No, I think that was really, really helpful. And I totally agree. And I think this is kind of such a practical reality for so many primary care providers that this is really, really helpful. We have to stop in a moment, but we have a couple of really quickies in terms of quick questions. So one is just how do you sort of determine whether someone's has orthostatic hypotension, is blood pressure or pulse more relevant? And the next question, also an easy, I think a short one, is what are your thoughts about the issue about percent of ideal BMI, which intake people always ask about?
Right. Yeah.
So if you could speak to both of those really quickly. Yeah.
So I care more about blood pressure, but you guys are the pediatricians, you know better than I do. I see a lot of orthostasis. I also see a lot of dehydration. And so the first thing I do is I give them tons of fluid to kind of make up for their volume depletion from not eating food and fluids. But I care much more about blood pressure. And I also care about the clinical experience of dizziness. Because I have patients on my unit who've been here for a month and their heart rates are going from like 70 to like 130, and they've been here for, a long time. And so that remains for a long time, that orthostasis by pulse. But I really care about, are they holding a blood pressure? We use percent of IBW, which is ideal body weight, which is a misnomer. It should be average weight. Just because in the pediatric world, it's easier to talk about than BMI. And so, we think of a normal IBW is 90 to 110%. And we're concerned about, if someone's 65% or less, they should probably start off in a medical setting unless they're able to eat pretty solidly. And, obviously we're trying to get people up to where they should have been, but usually in pediatrics, that's at least 95% of IBW. But was that the question about IBW specifically?
Yes,
Yeah.
I think so. And thank you so much, Dr. Deshant. This brings us to the end of our time. So we're going to close the session, but there was one other question in the chat, which I will send to you, and we can email a response to that. But this was a really wonderful presentation. And thanks everybody for attending. And we look forward to seeing people next month.
Okay, thanks.